Full Bloom is brought to you in part by the following. Welcome to Full Bloom, the award-winning show that celebrates life. Here's your host, Zita Christian.
Hi everyone, welcome to Full Bloom. I'm Zita Christian. Tonight we're going to continue our four-part series on dementia and caregiving. And my guest, Pamela Atwood, who is the Director of Dementia Care Services at Hebrew Healthcare, is with us again tonight. Pam, welcome back to the show.
Thank you for having me back, Zita.
You know, we talked on the first show about some, an overview and about the differences between Alzheimer's and dementia. Alzheimer's being a type of dementia. I loved your analogy about the furniture. That worked really well. And we talked about the caregiver, and I want to talk more about that tonight. The caregiver, caregiving in general, the importance of the caregiver. I don't think people realize the importance of that role.
Absolutely.
And
right.
we will change that. But first, I want to ask you, at the risk of sounding stupid, because I'll take that risk every time. I always heard that, if someone had Alzheimer's, they lost their memory. And then people talked about dying from Alzheimer's. How could you die from losing your memory? I don't get it.
Oh, great question. It's not that you're dying from losing your memory. What's happening is Alzheimer's is a disease that's destroying the neurons in your brain. And the first neurons it goes for, or most significantly that we recognize as symptoms, are memory cells. So it attacks the thalamus and the hypothalamus and the temporal lobes, these areas in the brain that convert information from sensory information to short-term memory and then to long-term memory. So those are the first cells that are affected by a disease like Alzheimer's disease. As the disease progresses, it moves all over the brain. So eventually it is affecting the cerebellum, the back part of the brain, and destroying those brain cells. Those are the cells that affect your function, your movement. So if I say to you, for instance, go to the bathroom and brush your teeth, that goes through at least 4 different parts of your brain. First you're saying, she's talking to me and she wants me to do something. If I say, Dick, go to the bathroom and brush your teeth, somebody in the studio is thinking, does she really want me to go do that right now? You, Zita, are thinking, oh, she's not talking to me. And then it says, do I know how to do? Second part of the brain. Do I know how to do what it is she wants me to do? Like your big card catalog in your brain that says, do I know how to make a souffle? Do I know how to drive to Boston? Do I know how to drive in Boston? All right. And I know me too. Do I know how to go to the bathroom and brush my teeth? Once I get from that part of the brain to say, I have to physically go to the bathroom, that's in the cerebellum, the back part of your brain. And then once you get to the bathroom, you need certain tools, and they need to be done in a certain order, certain sequence. Those are the frontal temporal lobes of your brain, the very executive functions in the front part. So it goes through different parts of your brain. As the disease progresses, and for Alzheimer's disease, as opposed to other kinds of dementia, we're talking about plaques and tangles that accumulate in the brain cells that kill the brain cells. So this plaque that accumulates, and it's a sticky kind of plaque made of a certain protein called amyloid. And there is naturally occurring amyloid, but we're not sure why people with Alzheimer's have an excess amount of amyloid, and that we don't have a way to stop the production of it or clear it out efficiently. There's all kinds of different research schools. So some people say, well, it's not the amyloid, it's the inflammation. Or some people say, well, amyloid's natural, we've got to flush it out better. And some people say, no, we've got to break it down. So there are all different kinds of research studies going on now about what makes it happen. We don't know. What's the real cause, and how do we stop it or prevent it or cure it? And of the big 10 diseases that cause death among older adults, Alzheimer's is the only one where we don't have an effective way of treating or preventing it. So for instance, cancer, we have some ways to treat and prevent. Lung disease, heart disease, we have some ways to treat and prevent. With Alzheimer's, we don't. And all of the other numbers of those big death causers for older adults have been going down in the last decade. Alzheimer's numbers have increased 66% in the last decade. So how do you die from it? It's because it's killing the brain cells that control the rest of your body. So for instance, my grandmother technically died of kidney disease. She didn't have a kidney failure. She didn't have any disease in her kidney, What happens is your brain is telling your body how to process your coffee, your lunch. It tells you how to breathe. It tells you how to swallow. Her brain no longer told her kidneys what to do. So eventually that's what ended her life. For many people, they'll die from an infection, very commonly from an aspiration pneumonia, which is where, it's like if all of a sudden I swallowed wrong, we have that kind of feeling. And for an infant, that reflex determines whether or not we can give them food or thickened, milk or whatever. For people with Alzheimer's disease, they literally are forgetting how to swallow because their brain is no longer differentiating which tube the food or fluid should go down. So it goes down the wrong pipe. And
so something physical happens that causes the death, but the physical thing that happens is because the brain isn't communicating.
Correct.
Okay.
Because of brain damage is really what it comes down to.
All right.
If enough brain cells die, your body can't work.
So that kind of brain cell death then is similar, I'm assuming, if a person has a stroke or...
Correct. It depends on the type of and the severity of the stroke and whether or not the brain can function and compensate around it. So whether it's a stroke or Lewy body dementia, which is a similar, it's actually kind of the crossroads of Parkinson's and Alzheimer's, or Parkinson's-related disease, or frontotemporal dementias like Pick's disease. There are lots of different kinds of related disorders that affect people's brains. And if enough of these cells die, your body shuts down.
Thank you for clarifying that. That makes much more sense now. Another thing that I've always wondered, we think of Alzheimer's and dementia automatically connected with old age. And I understand based on some of the things you said, I get the connection. But does it ever happen to somebody earlier in life, like to somebody younger?
Yes, it does. And there are actually more and more studies being conducted to discover that there are pockets of people who are very young getting Alzheimer's. Now, every once in a while I hear a report about an 18-year-old who has Alzheimer's. I question that. That is probably not true. It's probably some rare disorder that has similar features because of a memory impairment. So people assign it as Alzheimer's, but it's not technically Alzheimer's disease. But there are people who are younger, what we call the younger onset Alzheimer's patients, the most famous of which right now is Pat Summitt, the
coach of Tennessee. Yeah,
exactly,
the Lady
Vols. Exactly. So, there are people who are under age 65 who can get this disease. There are some family traits to this. Some of this is genetic. It does tend to run in families, and that's more common for those folks who are younger. So if younger onset Alzheimer's runs in your family, that's more likely to be a pattern or a trend, familial, as opposed to older onset. Now, older onset Alzheimer's runs in my family. I won't be surprised if my dad gets it. I won't be surprised if I get it. We're all prepared. We know what we're going to do. We're going to have a good time, actually. But the thing is that for younger onset, you're often dealing with very different situations. These are folks who are still, having kids in high school or college. They've got mortgages. They aren't schooled in Medicare options. They have bills to pay, and they're not retirees living off, their savings, which, that's a generational thing. My generation's never going to have savings to live off of anyway. But, these are really different issues. So younger onset can happen.
Okay. Even as we're saying this, I'm thinking, that's awful. I can feel the weight like on my shoulders. But because I know you, because we've had a preparatory conversation about this, and I want to be sure that you know in the audience too. This 4-part series is going to look very candidly at Alzheimer's, dementia, at caregiving, as an overall umbrella for a lot of this. And some of it is disturbing, there's no doubt about that, but there's a lot of hopeful information as well. When we get to the 4th show in the series, we're going to answer your questions. So you're going to see Pam's email shown several times during the show. And when you see it, and thank you very much for agreeing to do this,
my pleasure. People
can send their questions to you. And on that 4th show, where we talk about all the progress that's been made, and we talk more about how people can prevent at least some of the contributing factors. And then we can also answer people's email, because I'm sure that this series, I hope, will generate interest and, more importantly, conversation. Get people talking about this. So some of these specific things. Let's talk about Pain management.
You know, as we're talking about hope,
Yeah.
this is one of the areas that I think is really crucial, because whether it's younger or older or whenever these kinds of conditions strike, and I get this because when I work with my support groups, when I'm teaching classes, when I'm working with caregivers or individuals, we have a support group for individuals with early stage memory disorders. You know, we're talking all the time about hope, about medications, about support, about finding opportunities to connect, and pain management's really critical here, because nothing kills hope like pain. And I think that the more we understand, and we're just coming now to really understand how much people with dementia are feeling pain and not getting the treatment that they need. This is, again, when we're talking about caregivers, about what a clinician needs to know, this is where the family can help. For instance, have you ever had a migraine?
No, I haven't.
Oh, you're so lucky. Okay, for all of your viewers who have, they're miserable. And what I do for a migraine is very different than what I do if I stub my toe or bang my knee when I fall. It's also very different if I'm stressed and I have a hangnail. So we have multiple different kinds and sources of pain, and different ways that we are treating pain or are affected by pain. So for instance, if I fall and hurt myself, I'm usually swearing. No one can touch me. I need to control my pain.
Yeah.
And eventually I'll probably take a painkiller, you know, over-the-counter, like ibuprofen or something. If I have a headache, I need to be coddled. I need something warm. I need quiet. I need everybody to be aware that I'm in pain.
Yes.
Okay? Very different. Now, if I have Alzheimer's disease, I'm not going to be able to tell you that. Instead, I'm going to respond with a behavior, because if you're too loud, or I don't like the lights, or I'm smell sensitive, I'm olfactory sensitive, I'm just going to hit or strike out or scream or yell or whatever. And a lot of times, what we knew about Alzheimer's disease was wrong. So we believed that these folks had behavioral disorders, that they were having hallucinations or delusions, or were aggressive or assaultive. We now know most of those triggers are things we can control. They're either in the environment, or more often than not, they're pain. So pain management's really crucial. I always say, it's like people expect that when people get Alzheimer's disease, their arthritis is cured. Of course, I mean that facetiously.
Yes, of course.
But if you think about older adults who are in nursing care facilities,
Yeah.
or in adult day centers, or getting home care at home, how often do they say, man, is it going to rain? My wrist is killing me.
No.
They don't say that when they have Alzheimer's. Instead, they withdraw.
But the wrist is hurting.
And they're holding it like
Yeah.
this, and we need to look for those symptoms. So informed education about pain symptoms, assessing it and treating it is really vital.
And that gets back to the thing that we're talking about, the caregiver. The caregiver is the one who's going to be noticing that. And we talked a little bit in the first show about how the daughter and then the daughter-in-law are the two primary caregivers, the ones who kind of fall naturally into the role. But I want to talk more about caregiving, the different types of caregiving. Before I get to that, though, I do want to focus for a moment on one specific thing, because I know that it's something that affects a lot of families, and that's that whole issue of dementia and driving.
Oh, yes.
How do you talk to your parents?
A lot of this depends on how you always talked to your parents. And I know we're going to, if we have time, talk a little bit about role reversal, which we should never, ever do.
Yeah.
But if I all of a sudden start talking to my mother about her driving, well, my mother and my father taught me how to drive. So who am I to say that they no longer can, or if they're not doing it correctly? You know, even my sisters and I get bristly if I go, if she cuts the corner too sharp, or, you know, I mean, we're very sensitive. In our culture, driving symbolizes independence and the ultimate of competence. So, it's a little different in some areas. New York City, most of the people don't drive, but it's very different if they could, and now you're saying that they can't. Maybe it's an accident, or someone's cut too close, or they got a little lost because of a detour. You know, I can remember back when we had the big snowstorms a couple of years ago, and all of the power lines were down for like 9-10 days. I know Bloomfield pretty well. I had to take a detour around some live wires. It was getting dark, and I didn't really know the area. I wasn't afraid of the neighborhood. I was afraid I was going to run over some live wires. And it is a very unsettling, scary feeling. Imagine if you have a memory impairment and you're trying to cover that up. and someone now calls into question something that you think you're working really hard at and you don't want somebody to discover, again, their two fears: they don't want to be seen as crazy or stupid. So to take away or to question someone's ability to drive is a huge, difficult situation. I find for most families, the sooner you start talking about it and give the individual in the driver's seat all of the driver's controls. So for instance, I would say to my mom, gee, Mom, I know it someday we may have a conversation or have to have a conversation about driving. How do you want me to handle that? Let my mom tell me how she wants to be talked to. Would she rather that come from the doctor or from her husband, my dad, or from me or my favorite younger sister? You know, who's the one who's going to be the safe person to have that conversation? Then you need to be educated as a caregiver and say, what are the symptoms of problematic driving? And there are some great resources available from a number of different resources. Again, folks can email me. I'll send them a link or a brochure. And there are worksheets to say, have you had this problem or that problem? Has this ever been an issue? Are you concerned about that? Have you noticed this change? And then it's very objective. This isn't me saying, Mom, I think there's something wrong with your driving. It's, I filled out this worksheet, and these are 3 areas of concern. What do you think about that? Now, maybe it is your eyes. And sometimes people are willing to give up or change their driving habits for other reasons. Well, you know, I'm older now, and my eyes aren't good, and the headlights are a little glary, so maybe I'll change, and I'll no longer drive at night. So many times, older adults will self-correct for their own changes with an excuse that's acceptable to them. I don't force people to acknowledge a problem they're not willing to acknowledge. I'm willing to use whatever language they want as long as the problem of the dementia and the driving is addressed. Sometimes that doesn't work. Sometimes we need to disable the car. Sometimes we need to file down keys or take off the distributor cap. Sometimes that doesn't work, and the individual with the memory impairment is very capable and calls up the local car dealer and says, there's something wrong with my car, you got to bring me a new one. We hear all kinds of stories.
Wow.
But ask us, talk to us about the challenges. We're here to help.
You know, you mentioned just a minute ago when you were telling that story, you referred to your sisters. And I'm wondering about the whole thing when you have siblings as caregivers. My family, we had a situation like that when my dad was dying, and I have 2 younger sisters. I thought, if I say so myself, I thought we handled it beautifully, absolutely beautifully,
well, then you're one
to
of
this
the
day.
few.
And from what I've heard, that is the case. So I do feel very fortunate. But how does that usually work? What are some of the challenges there?
Any challenge that's been in a family dynamic by history will be brought out to its worst nth degree during the stress of caring for someone who's older, and especially if there are issues that you don't agree on. So, for instance, my dad always lines up the 3 girls, me, Debbie, Abby, and says, this is my retirement plan. I work with older adults. My sister Debbie's a nurse. Abby is the business person. Debbie and I have very different beliefs and feelings about end of life and advance directives. All right, so that's one thing where she and I don't agree. We should never be put in a position to fight about what Mom or Dad wants. Mom and Dad need to be the parents to say, here's what we want, and here's who's going to help us enforce our wishes. And there are all kinds of documents and advance directives where people can declare that. Now, with my grandmother, who had Alzheimer's disease, she knew she never wanted feeding tubes. She never wanted to be kept alive on a respirator or anything like that. No artificial nutrition, hydration. So she knew those things. It was very easy. There were no fighting. There was no fighting. There were no disagreements amongst the siblings or the family because we all knew what she wanted, and we were honoring her wishes by enforcing that. That made it much easier to be a caregiver. So the more that an individual, and this is for every one of our viewers, this is for me. You know, here I am with 2 little kids. I need to have put down, and I have, in writing, my wishes. Heaven forbid a car accident happens or something.
Yes.
My family shouldn't have to worry about who's going to take care of the kids, do we disconnect to whatever. You know, we need to have those conversations much more freely than we do currently in our culture.
Absolutely, we do. I just want to say, too, for the viewers in the audience, if you're just joining us, this is Full Bloom. I'm Zita Christian, and Pam Atwood is my guest tonight. She's the Director of Dementia Care Services at Hebrew Health Care Organization in West Hartford, and they have facilities in various places in the state. We're doing a 4-part series on caregiving and dementia. This is part 2. When we get to part 4, we're going to answer your questions. You'll see Pam's email address several times in the show. So I'm inviting people to send their questions to you. And also, let me just say, if you're finding this show but you didn't see part 1, you can always go to YouTube, and you go to youtube.com/Zita3x3. That's our channel on YouTube, and people can pick up these shows, and they'll be up there at any time. I want to ask specifically now about caregiving styles, because I understand that not everybody does it the same way.
No.
It'd be pretty obvious, I guess. But what kind of different styles might there be?
There are a lot of different styles. Again, part of this comes from our own personal background, culture. You know, in some cultures, I've had our physicians who will say, you know, I talked to my patient and they said, yes, they would take this medication, and they said they understood how to take it, and I reviewed it with them and I wrote it down, and I'm here to tell you, 3 months later, they've not taken the pill once. And, you know, there are lots of different things. Some cultures will say yes, yes to the doctor and have only herbal things that they'll take. Some people want pills for everything. For caregiving, just as we're all individuals within our families, within our cultures, within our upbringing and our communities, caregiving here in Connecticut is or in New England, very, very different than in rural Idaho, where you have fewer resources and greater distance between families and the loved one with a memory impairment.
Right.
So every caregiving situation is very different. There are lots of things that, again, when we talk about the messiness of caregiving,
yes,
that's where some of these styles come in. So I have one caregiver who says, I'm an only child with 6 siblings. Because she is the one caregiver for mom, and the 6 siblings want nothing to do with the caregiving. They've got their own families, they're long distance. One of them's 4 minutes away, but the caregiver whose primary is 2 hours away. So those are some of the the different kinds of caregiving situations people find themselves in. Some caregivers are natural born caregivers. They let mom take they're not going to argue with her. They're just going to take care of her. They honor, respect, adore. There are some people who are very much, this has to be my way. We have to be efficient. We have to take care of this immediately. And some people are kind of stuck in between. Some people are riddled with guilt. Oh, this is because, culturally, again, the Asian cultures, a lot of the Chinese cultures, my coworker in my office is from Hong Kong, and a lot of the Asian cultures, she's informed me, believe that if you get Alzheimer's disease or another kind of dementia, it's punishment for the sins in your previous life.
Oh.
So a lot of times people don't talk about it at all because of the stigma, either culturally or because of the stigma associated with Alzheimer's disease. So people can get very isolated. Some of us are very healthy caregivers. I never have an unexpressed emotion. I'm not going to suffer alone. I'm going to find friends. I'm going to engage in support groups. I'm going to get education and information. What we do know is that the best caregivers get a lot of education, a lot of information, a lot of support, and use good spirit, whether it's humor, religiosity, spirituality. There's some other way of restoring that caregiver.
That leads me to a statistic I wanted to be sure to mention on tonight's show. We talked about it on the first show, and we're going to talk about it on all 4 segments of this series, and that is that in one study, 80% of caregivers described the experience as rewarding, enriching, but 65% of caregivers die before the death of the person they're caring for. 65%. The stress level has got to be overwhelming. Yes. So I look at that and I say, well, a caregiver has to be trained. Absolutely has to be trained, not only in how to do it without burning out, but in caring for the patient, but also caring for the self.
Absolutely. We say for instance, with Alzheimer's disease, that there are always at least 2 victims, the individual with the progressive memory disease and the caregiver. Because, my grandmother, when she was living with us, my mom used to say, you can't run around your house naked. Not that you would, but you can't. Because there's an inordinate amount of stress in being responsible for someone else 24/7. And a lot of times when we have someone who, if there's an illness or a fall and the person who's the caregivee, if you will, goes to the hospital, all of a sudden the caregivers feel this great sense of relief because it's on someone else's clock. It's on someone else's watch. The stress of being responsible for someone else like that, it's very different, and it's we're all designed to withstand some stress, but not for an extended period of time. And that's why the caregiver burden associated with dementia is so much greater, because these are not like some of the cancers, which are 2 or 3 years. Alzheimer's disease can last 20 years or more. So we're talking about caregiving over extended periods of time.
I know that you have a program out at Hebrew Healthcare that addresses caregiving.
Yes.
We have can you give us about a minute
Sure.
to tell us about that?
It's called Aging Care Academy, and it's not dementia specific, although we do a lot of education and coaching around dementia care. But it's for anybody who wants information about heart health, normal changes with aging, nutritional issues. It is based on like a college concept, although there are no entrance exams and the tuition's much less. I mean, we are a nonprofit, so we are very aware of the fact that we're not out here just to be making money on this. Aging Care Academy looks at what are the core things you need to know. You need to know about Medicare and Medicaid and when not to be spending your money or gifting it. You need to know about caregiver resources. You need to know about, the state's best kept secrets in resources to help people stay out of nursing homes. You need to know how to stay out of a nursing home, and I've got 6 specific tips on how to do that. There's a whole course on that. So they're each 90-minute workshops taught by our experts at Hebrew Healthcare, our geriatricians, our social workers, might be on mood or avoiding the blues, but they're wonderful courses. It's promoted and supported by Farmington Bank Community Foundation. They gave us the seed money for the grant.
Oh, that's excellent.
And it's been a fabulous program.
And I'm so glad that you have that. And it's close by.
Yes.
I want to say, Pam, as we close this segment, that this is part 2 of the 4-part series. And when we come back for part 3, we're going to talk some really sensitive issues. We'll be getting into intimacy and aging, sexuality and aging, a segment about veterans and dementia, and about laughter therapy. And as I said earlier, in part 4, we're going to be answering your questions, talking about the latest developments, the progress that's being made, and why there is hope. And on that hopeful note, Pam Atwood, thank you very, very much for being on the show again tonight, and I look forward to doing part 3. Thank you also in the viewing audience. And I want to close with the quote that I found by the author and motivational speaker, Brian Tracy. He says, "In life, you can never be too kind or too fair. Everyone you meet is carrying a heavy burden." Please remember that. And do join us again next time. Thank you.
Is brought to you in part by the following.